So, preference? Which was, let me ask you this. What movies did you get to see?
I saw The Woman in the Window. I like that.
I watched both.
I watched both. I watched The Woman in the Window. I watched both.
Okay, so we got the next couple. We're covered. All right, so preference. Let's go low-hanging fruit. Woman in the Window first. All right. So, all right. Initial thoughts. Any particular character you identified you prefer to discuss?
Start with the main character. Yeah, Amy Schumer.
Amy Adams?
Not Amy Schumer, sorry.
No, I watched
So, trying to resist the temptation of jumping to a diagnosis, or really using any medical drug, what did you see? So here's the mental prep. We have one, let's multiply her. Let's say that we have a dozen undergraduate students from Rutgers University. And they didn't get to watch this movie, and in preparing for a discussion, they asked, hey, quick, explain this character. What are the first words out of your mouth?
Recluse.
Huh?
Recluse.
Recluse, okay, go on.
Drinks alcohol.
Drinks alcohol, excessively? Excessive use of alcohol, recluse. In grief?
Unfriendly.
Unfriendly.
I would just tell them that she doesn't like her house.
Doesn't leave her house. Did we ever see any scenes where she does or tries to leave her house?
Yeah.
What happens?
She like,
False. All right. What else? Does she fall because of impaired gait secondary to excessive alcohol use?
No.
Potentially suicidal.
Suicidal? There's a lot going on with this character. If you had to think, or maybe put on your producer's cap, if you're going to make a sequel or rewrite the script, and she were to present to clinical attention, what would you write in as her chief complaint? What would be most intriguing?
agoraphobia.
No, her chief complaint.
Oh.
If you have a patient that presents with that as a chief complaint, run. I mean, you named plenty. There's a lot going on here. I guess what I'm asking is, what might be the reason why something precipitates that results in her seeking care?
I mean, since her family passed away, I think her
See-
whole mental status likely was definitely impacted. So she just may not feel right or sad after that.
Okay,
For
so-
an extended period of time, that may not be normal.
Right. She might come to clinical attention secondary to grief. It's fine. I mean, again, there's no wrong answer. So, grief. All right, so, and that's actually a great answer, given how I would prefer to kind of go about this discussion, which you heard this morning, you're going to hear again, and you're going to hear several times. And that is, if you learn one thing from this courtship and go on to your non-psychiatric career, it's to always start off with point A, that what you are viewing, observing, or otherwise being told by a patient to be normal. All right, until you're provided evidence to the contrary. Irrespective of how overwhelming that evidence appears to be, stay neutral, unconditional positive regard. What you're hearing is normal. Right? So give me some background, especially that which could appear on a shelf exam, about the normal grief process. What do you know?
Didn't it just change? Didn't they just
Well,
had a new diagnosis?
Well, a lot of the feelings they'll have can mimic depression, but it's usually like an appropriate response to the situation.
Okay. And give me 5 examples of how that appropriate response may manifest.
Sleeplessness, crying.
Disinterest in normal activities.
Okay.
They can see they can have like a hallucination of the person that died, and they can also have feelings of like wanting to join them.
Okay. Now you're right, and maybe splitting hairs just a little bit. we're talking not only now about the grief response, but also bereavement, right, which is a clinical syndrome. A lot of what I'm hearing is consistent with bereavement as well. The grief response can actually progress through several stages, and there's no linear progression per se. What are those stages?
Denial.
Number one. But wait a minute, time out. You heard that in neuron brain and behavior, denial as a defense mechanism was immature and abnormal, right? Denial is I think as we mentioned earlier, an appropriate response to the death of a loved one, and is often an initial response, and in such cases can be very adaptive. So forget what you learned in neuron brain and behavior. Tongue in cheek. Any others?
Anger.
Yes. Anger. Others?
To the end, acceptance.
Acceptance, good. And to your point, I'll put words in your mouth, these do not always go in order, right? They're published in a certain order, but Elizabeth Kubler-Ross was quick in follow-up to not only apply these to non-grieving states that were related to malignancy and cancer, which was her initial manuscript, but also was very, very clear in that individuals need not proceed through these in any linear manner and can often repeat steps. We're missing a couple.
Bargaining.
Yes. The other one you already mentioned is depression, which could include additional signs and symptoms that themselves may represent a related but separate syndrome called bereavement, right, which is published, which is in the DSM. Bereavement is a syndrome that may or may not be clinically significant, but certainly if clinically significant, must also include in the differential diagnosis a major depressive episode. And certainly if it persists or recurs, even major depressive disorder. Good. Risk factors. Person comes in, you are giving them the benefit of the doubt, unconditional positive regard, but they ask you, hey doc, what are some things that might pose risk of what I'm dealing with now continuing and maybe becoming depressed, maybe having major depression? Your answer?
History of depression.
Yeah, right. That's a big one. Right? Prior history of major depressive disorder. Others?
Substance use.
Yeah. And that you could also kind of fold into a larger rubric called maladaptive coping, right? So not only substance use, which is in and of itself an independent risk factor, it is. But if you're thinking of substance use as an example of maladaptive coping strategies, well, there's others that are there too, like cutting, and certainly many others. And then somewhat related to that is social support. And lack of social support can be its own independent risk factor. Do we see any of that play out here? Which ones?
Alcohol.
Yeah,
Seems like she doesn't have social support.
yeah. So I think two of the big three. There's some of this script that appears to be evidence-based. Any questions about the grief response or grief reaction, bereavement?
Yes. When should normal bereavement end? What's that time frame? You now diagnosing this person with depression?
Yeah, so that's always the question, right? And there's a bridge between normal bereavement and major depressive disorder. And that bridge is called persisting complex bereavement disorder. Otherwise shortened to complex bereavement. It's very, very specific, complex bereavement. This syndrome, again, I think it's persisting complex bereavement disorder, is thought to be that bridge between what is culturally sanctioned to be normal versus that which is diagnosed as major depressive disorder.
Is that boundary at 1 year? Is that the new criteria?
So there's both quantitative as well as qualitative parts of the diagnosis. I think the qualitative is very easy because anything that is disturbing to self or others, including the clinician, qualifies. So not only the idea of wanting to be with the deceased, but active suicidal thoughts. So I think those things are pretty straightforward. Believing you see the deceased individual is one thing, but having visual hallucinations that impair functioning is another. So again, I think they're relatively straightforward. They are listed in the DSM, but as you read through them, I think everybody in this room is just going to nod at every one of them that's listed. The qualitative part of the definition is a little bit more difficult because the APA really doesn't put solid guidelines in terms of timeline. It used to be 2 months, but they changed it. They changed it because of a couple of reasons. Number one, my point is that there is no consistency in the literature to suggest that there is a real timeline. And the other part, which is where bereavement sat as a needed rule out in order to rule in depression, didn't fly either. Because they actually looked at a lot of case reports, a lot of data, and what was suggested is that bereavement is often the etiology of a major depressive episode, and therefore you shouldn't avoid diagnosing MDD with any evidence of bereavement. So that didn't fly either. So with all that being said, we really don't have a solid timeline, but we know that it's certainly longer than 2 months. Right? So persistent complex bereavement disorder. I will tell you that more times than not, when the American Psychiatric Association operationalizes chronicity, it's 6 months or more. So at 6 months, I think the clinician should start to look at alternative diagnoses, including MDD. Make sense? Okay, good. There was something else I wanted to bring up too. Maybe persistent complex bereavement disorder. Oh yeah, because I actually alluded to this twice now. The way I phrased the initial question, what may have precipitated her coming in to see you, everything you listed are ongoing problems of hers. When a person presents to clinical care, when you see a patient, especially in psychiatry, not only should you consider things that might be biopsycho or social factors that impact the person's well-being or behavior, but additionally always think of only 3 Ps. What predisposed them to come in? What was the precipitant? And then what perpetuates the behavior? And if you build a 3x3 rubric with biopsychosocial across the x-axis and predisposing, precipitating, and perpetuating the y-axis, when you take a patient history, transcribe your notes into those 9 boxes because you have a real good idea then how the case formulates what's going on. What predisposes someone does not always precipitate their coming in to see you. And psychiatrists, especially in psychotherapy, always ask, why now? What happened that allowed this person to realize or make a decision that today should be the day they come in for help, especially when they present to the ER, especially, for example, suicide attempts. Why now? Right. And all right, so other than the mood component here, and I think the next thing to think, well, let's look at this as a case of major depressive disorder. All right, for major depressive disorder, there are a few things we have to consider for that might actually explain the observed behavior. And if you investigate these 4 conditions and rule them out, then MDD becomes your most likely diagnosis. So MDD is a diagnosis exclusion as per the American Psychiatric Association. I want to now have a conversation about those 4 conditions. We now want to deep dive and investigate.
Like medical conditions that you need to rule out?
So, we'll just say as a general. We're not going to get into each and every medical condition. But yes, medical conditions need to be investigated and ruled out. The last thing you want to do for your patient, and certainly you in your practice, is to diagnose a mental disorder and have an occult medical condition then manifest that has been causing this the whole time. So general medical conditions or other medical conditions should be at the top of your list. 3 more.
Oh, as a hypothermia.
Well, that's an example.
That's one of the 4.
Yeah, I'm not going to waste your time.
Oh, got it.
and ask you to list
Yeah,
the
yeah, yeah,
180 medical
Okay.
conditions that are presented. And by the way, the shelf is like this too, right? If there's evidence of a medical condition, 99.9% of the time, they're going to expect you to know the timeline to have, let's say, depression due to another medical condition be the single best answer. They are not going to ask you to identify the pathophysiology. So they're not going to establish the timeline and then list 4 common medical conditions and then expect you to know which one is likely to induce depression. That make sense? The timeline is critical. That is, an individual will present with a chief complaint that is behavioral. And upon H&P and further investigation, you find that occult medical condition that explains the behavioral disturbance, the behavioral change. That's the timeline we want here. What you don't want is someone to present with a physical complaint, find an occult condition, make the diagnosis, and then have the patient become depressed upon hearing the diagnosis. That's called an adjustment disorder. The timeline is critical. That's what you're going to have to look at in your case vignette to choose due to another medical condition as your single best answer. You do not have to know the pathophysiology. All right, so I want 3 more illnesses.
Substance.
Good. A substance induced. In this case, depressive disorder. Good.
Would you have to be ruling out bipolar
You
disorder?
absolutely would have to rule out bipolar disorder. And the other one is schizophrenia. So the big 4. Any of them play a role here. Well, let's start off with either schizophrenia or bipolar. Any evidence that this may be a fictional case of schizophrenia or bipolar affective disorder? Any evidence of hallucinations or delusions?
In
In our patient?
the patient, and we're referring to pneumonia. She was.
More specific?
Visual and auditory hallucinations?
She was suffering from both visual and auditory hallucinations. The reason why I bring that up is that individuals with an established mood disorder with co-occurring psychotic features are more likely to have bipolar. That is, it occurs up to 50% of the time in bipolar patients, whereas it is less than half the incidence in patients with major depressive disorder, like 10 to 20%. So significantly more. Does that mean that this is then an obvious case of bipolar that's presenting depressed? No. Now, it's something to consider. And certainly in a clinical practice, in a clinical venue, would result in you asking the questions of date fast, present, recent, or at any time in your past. Have you ever had a manic episode? Review the date fast criteria. And if the patient endorses for those symptoms, then we have a new diagnosis to consider. Well, schizophrenia.
Well, it's just difficult because, like, you could have major depressive with psychotic features, right? And that's different than bipolar.
Absolutely.
And how do you differentiate those specifically? I think that's usually best.
So in a slice of time, and we'll use the movie as an example, it's very difficult. So we have a patient. By the way, what's the term first name? Anna? We'll call our patient Anna, who's sitting right in front of you with co-occurring dysphoria and psychotic features, which I'm told, everybody's in agreement, is actually happening in this movie, right? There are 3 things to consider here, so let's break this down. Number 1, 2 things should come to mind when you are talking to someone like Anna, who is presenting with co-occurring depressive and psychotic features. One is a primary depressive disorder that is severe with psychotic features. The other one is a condition called schizoaffective disorder. So that's got to be our first question. How we tease one away or apart from the other. How do we tease one from the other? Okay, I'm going to answer your question with a question.
Psychotic features only occur during depressive states.
Exactly right. When there's evidence of one without the other, then we know which one we're talking about. So the patient's history is going to help you tease that out. Now, that's in a textbook and that's in a shelf vignette, but in real life,
Hard to tell.
very hard. Very, very hard. But that's what you have to look for. Give me a slice of time, give me an established time frame, the longer the better, where the individual will tell you, yes, I was CDCAPS, and no. From 2013 to 2019, I didn't suffer a single hallucination or delusion. Here's your diagnosis. This must be a primary mood disorder then. And therefore, the primary mood disorder is likely MDD with psychotic features. ... There's more to come there. On the other hand, you just flip-flop that. And the patient tells you, yes, between 13 and 19, I did have delusion, and I did have hallucinations. But there wasn't a single sign of depression. Well, this must be a primary psychotic process. And the most likely diagnosis, schizoaffective disorder. So that's first and foremost. Let's get back to choice A. When a person tells you that for an established time frame, they've had CDCAPS with no evidence of psychosis whatsoever. The next question is, all right, there are two things that I still need to consider. Whether your CDCAPS is an established major depressive episode, and therefore, your most likely diagnosis is MDD with psychotic features, or maybe your CDCAPS was part of a larger disorder called bipolar. And this should be bipolar disorder with psychotic features because mania, or I should just say depression, was the way it presented. Well, the patient's history is the only way you're going to be able to tease that out. And that is, at any point in their life, and since we're talking about Anna, at any point in her life, did she ever experience a manic episode? Because if the answer is yes, when she was 6, there was a manic episode. Book it. And I'm not going to try to trick anyone, let's just say it's there. Now what you're dealing with is bipolar, albeit bipolar depressed phase, with psychotic features. But the patient's history is the only thing that is going to be able to buy that forward.
So it's really during any point in their life, if they're manic at any time, even though the depression's only been the past year, let's say, 10 years prior. Okay.
Exactly right. Exactly right. So again, Anna is about 35, 40, maybe? If she's presenting and we establish this is a primary mood disorder, and major depressive disorder with psychotic features jumps to the very top of our differential. If we find in the script, if we get that patient's self-report or family's report that when Anna was 20, she had a florid manic episode, she had a discrete episode of dig fast, which lasted 7 days or more. Average length of time is 3 months. Then we change our most likely diagnosis. Now, this is a depressive phase of bipolar disorder because of evidence of a past or prior manic episode. Any evidence? Remember, manic episode could be right now during the HPI. It could be recent, or it could be in the past psychiatric history. Could be any.
I don't think she showed any mania.
So for now, we'll say MDD with psychotic features versus schizoaffective. My gut says is that it's major depression with psychotic features because you gave me a potential etiology of depression. We wouldn't think that bereavement would involve in a psychotic process or a primary psychotic process. Where does substance use kind of fit in here? And the question is, cuts across everything we just discussed. Every single disorder and the way we went about teasing out these different disorders, including schizoaffective, major depression with psychotic features, bipolar disorder with psychotic features. In each of those 3 cases, we would not arrive at a diagnosis if we thought that she was also suffering from the direct and physiologic effect of a substance, specifically alcohol. So that will cut across all of this, as will any drug. Now, unlike medical conditions on your shelf exam, you do need to know which substances induce which mental syndromes or which mental disorders. That you're going to be held accountable for. So the best way is to identify the condition, let's say psychosis, and think of a drug that can induce it, and be prepared to address that on your shelf exam. If it's there, it'll be there once, right? You're not going to get more than one question where you're going to have to memorize the entire darn chart of every substance and which mental disorders that substance can induce. However, it's probably good to go over those substances right now that might induce psychosis. Any guesses of what those are?
PCP?
PCP, hallucinogens in general, yes.
Alcohol.
Alcohol, yes.
Cannabis.
Both intoxication and withdrawal.
Cannabis.
Cannabis, yes.
Okay.
Stimulants, yes. Any stimulant, cocaine, good. I think we're missing one.
Kratom.
Inhalants. Inhalants.
Where would you put kratom? I don't even know what to categorize this. Is this the new over-the-counter? I think it's a stimulant and something else.
So my first gut would be, I had to look into it, but my first gut would be stimulant.
Yeah.
Where's it sold? Like how's it
Gas
sold?
stations and such. I don't know. It's unregulated, but on the medical side, people are coming in with delirium and other issues. I don't know. One of the new.
I have to look into it. to be
Yeah.
honest with you.
Have you guys heard of it? Kratom? No.
General rule is that anything that could induce psychosis can induce dissociation. And anything that can induce psychosis and dissociation can also induce delirium. So those three are universally shared. And so those 5 substances you named not only induce psychosis, but there is such thing as a blank-induced delirium as well as a blank-induced dissociative disorder as well. Matter of fact, it is so consistent that the DSM, as of 2013, combined delirium and psychosis and just calls it, they just call it a psychotic disorder that is induced. So currently, there's no true diagnosis of, let's say, an alcohol-induced dissociative disorder. It's called, even though the person is completely dissociated, it's called an alcohol-induced psychotic disorder. They actually combined it under the psychotic rubric. All right. Any other questions here? Now, this conversation can pick up a little bit when we talk about April Fool's Day, and that is substance-induced disorders. So there's more to discuss that actually I think is in the plot of the other movie. But before we get there, let's talk a little bit about the anxiety component of this. Is it okay to say that this particular character experiences avoidant behavior or avoidance behavior? Is she avoiding going out? Okay. Now again, predisposing factors, precipitating, perpetuating. What perpetuating factor do you think plays a role? If she doesn't, her fear is that if she goes out, she'll endure some type of pain, right? By her staying in, when she wakes up the next morning and she looks back at the past 48 hours, how many accounts of pain can she record?
None related to going outside.
Right? So, what type of learning is that?
Conditioning?
More specific. Well, first of all, yes, is it classical conditioning or operant conditioning?
I think it's operant.
It is operant. Right? Classical conditioning is learning by association or associative learning. That's classical conditioning. Operant conditioning is learning by consequences. Consequential learning, this is operant conditioning. So what type of operant conditioning is in play? So when you get asked this question on your shelf, there's 2 questions you have to ask yourself. Number 1, is behavior increasing or shrinking or decreasing, weakening? We're talking about avoidance behavior.
The avoidance of behavior is increased.
It's increased,
Yeah,
right?
yeah.
If it's increased, this must be reinforcement. So take choices C and D that are the different types of punishment and cross them out. If behavior that we're identifying is increased, then your question stem will ask. If the question stem is identifying the avoidance, we only be dealing with reinforcement. Is something added or subtracted in this case?
Subtraction.
Subtraction, not going out. The subtraction is negative. If something had been added to the equation, it would be positive. So this is actually negative reinforcement. Right? So again, what precipitates this has nothing to do with operant principles. What predisposed to this has nothing to do with operant principles. But if you are treating your patient, not only are you thinking biopsychosocially, but you're thinking, all right, well, that middle part of the biopsychosocial treatment plan, these psychological factors that are in play here, must also be thought of in accordance to the 3 Ps. And when you look at the psychological perpetuating factors, we cannot dismiss operant conditioning in general and the positive reinforcement, the negative reinforcement in particular. Right? So another example of how to case formulate. All right, so avoidance behavior. Now this is going to get you in trouble on the shelf because if you see a patient like this, you might be inclined to peek at the answer set and then look, and what you'll realize is A, B, C, and D all may present with avoidance behavior. And anxiety disorders always get us into this trouble. So there's a couple of test-taking strategies we have to review. Number 1 is on your way if you're taking your shelf exam in person these days,
Yeah.
on your way in to take your shelf exam, you should be able to name every single anxiety disorder. If you can't, you are already behind the 8 ball, right? So between now and the final Friday of your rotation, you need to figure out a way, and we can discuss this in a different context. I have acronyms for you. You should be able to list every single anxiety disorder like that. That's half the battle. Number 2, so once you do that, you should know that for any that I blurt out, what the 1, maybe 2 clinical pearls are to identify and separate that one from the rest. Because that's what you actually have to look for in the case vignette. Know the answer before you look at the answer set, and then nail that question. Unfortunately, avoidance behavior is not going to do it. Right? So, let's talk about some of these conditions, the anxiety disorders that would be high for the differential. Can you name one?
Generalizing anxiety disorder.
I would not put generalized anxiety disorder in my top 5. I wouldn't.
Phobia?
Right? This is an irrational fear to an object or situation. And whereas in the past we had a specific name for each of the specific objects, that is no longer the case. That's the good news. What you do have to identify now are the different types of specific phobia. So do you know the 4 different types?
Social?
So social phobia is a separate diagnosis. But keep that in mind, please.
Agoraphobia.
That's also a separate diagnosis. But keep that in mind, again, it's going to be part of the larger conversation we're having. The subtypes include animal type, situation type, environmental, and blood injection injury. Those are the 4 types. And if your patient is fearful of clowns and that phobic object does not neatly fit into one of these categories, it's other. So again, the good news is that you don't need to know about chlorophobia, fear of clowns. That will not be a single best answer. But any of those base types, by the way, BASE is the acronym. Right? So blood injection injury, animal, situational, environmental, okay? Or grab bag, potpourri category of other. Another higher differential. So the pearl to look for the clinical vignette is very easy. Is there a phobic object? And especially if it's a phobic object that fits into one of those 4 categories. Next.
Agoraphobia.
The agoraphobia. What I want you to remember here is what the fear is. And if a patient was sitting in front of you, Anna was sitting in front of you, you would have to ask her, what is the fear? If the fear is about escape being difficult before embarrassing yourself or becoming debilitated, agoraphobia is going to be your simple best answer. So, what is the fear? Another? Social? Social anxiety disorder is very similar to agoraphobia, so it's going to present almost exactly the same, albeit with a different fear. It's the social or performance situation itself that invokes the fear, not fear of embarrassment. And so that's what you have to look for in your case vignette. And so we have agoraphobia, we have specific phobia, we have social phobia, social anxiety disorder. Any others? 2 more. 2.5 more. Actually, 3 more. So let me give you another 1.5. Avoidance behavior is defining of post-traumatic stress disorder. Therefore, this is the 0.5. Avoidance behavior is defining of acute stress disorder. So along these lines, the clinical pearl that you're going to really want to focus on are all of the other related symptoms of PTSD, including, but not limited to, nightmares and flashbacks. That will get you the diagnosis, as it will acute stress disorder as well. I think it's a 1-month follow-up. So that's your 1.5. The other 1.5 is, for avoidance behavior, is separation anxiety disorder. And the reason why there's a 0.5 attached to this is because separation anxiety is normal when age appropriate. So if the individual is about 18 months of age and you see this avoidance behavior, choice A, normal behavior is your simple best answer. However, when it's someone who is 11, and again, 18 months is when it peaks, they're not going to give you 19 months. They're not going to make you split hairs. But if they're age inappropriate, then it changes from separation anxiety to separation anxiety disorder. Here, the fear has nothing to do with where the person is going. It is not the social situation or performance situation itself, nor is it fear of embarrassment to where they're going. It has nothing to do with where they're going, but it has everything to do about where they're separating from. So that'll be the common thread, that'll be the common denominator. Separation anxiety disorder will be the single best answer. Right? Which one do we think Anna is struggling with? Agoraphobia. So you think that somewhere, whether it's explicit in the text or inferred, that she has a fear of becoming symptomatic and therefore escape maybe being difficult.
I think so. It's kind of like what happens when she steps outside, but I'm not sure.
I tend to agree with you unless there's evidence to the contrary.
I feel like she has to have a component of PTSD though too, because she had this traumatic life event and then definitely has re-experiencing symptoms, nightmares, flashbacks.
It would be hard to say that this is agoraphobia in the context of those signs and symptoms. That is, if we do think she's suffering from post-traumatic stress disorder, the PTSD likely is accounting for her avoidance behavior. It would be difficult to add on a secondary diagnosis such as agoraphobia then. So PTSD probably leapfrogs to top of the differential. And this, she's endured this greater than 1 month. So it's not likely a acute stress disorder. And again, we don't know how alcohol is probably a perpetuating factor here. If there's a true trauma, and that's been established, it's unlikely this is a substance-induced anxiety disorder. But there is a role that alcohol plays, and it's probably as a biological, biopsychosocial, perpetuating factor. Okay. So again, that's something you would stick probably in that 9th box. Any final observations or anything else I'd like to discuss? Were you part of Fiddler last night? Any of this come across the tweets? No? I wasn't there either, I couldn't make it. All right, turning to April
Real
4th.
quick, can I just question, Anna knew something was going on across the street, but she wasn't being believed because of her underlying mental illness. I guess I don't really have a question about it, but I just thought it was interesting that it's easy to assume someone with mental illness is not a reliable person, or at least not a reliable storyteller or and recaller, and that's we shouldn't make that assumption.
There is clear subversive text in this movie about how, quote unquote, seriously people struggling with mental illness are taken, and the stigma that comes along with being and battling mental illness. There's no doubt about that. Right? So yeah, that was a central theme in this movie, and unfortunately, it is a central theme in healthcare. People are readily dismissed, and because of that, they are given the indirect message to just hide in the shadows and suffer in silence. Irrespective of how many times we've tried to say there's equity, the fact is that there's a hidden agenda, and that the message they get is anything but that. That's very unfortunate, and it is very true. And it's very much part of this movie. Good pickup. 45? So we got a little while, well to 1 o'clock with, we'll do a 5-minute break, so maybe 10 or 15 minutes.